Hi, I'm Dr. Manimala Saradinayaka. I'm a consultant histopathologist and statistician. And in this short video, I'm going to talk about understanding functional medicine. Now, there's a lot of terminology confusion when it comes to functional medicine. It's also known as personalized medicine, and functional medicine is something that is very misunderstood among doctors, so much so that some people consider functional medicine a fake medical field, or they even call it alternative medicine. Okay, that is completely untrue. Functional medicine is very mainstream for those doctors who understand research methodology and statistics. Now, let me explain the issue with an example rather than going into a lot of technical details. The first thing that you have to understand is what is an individual characteristic versus a population characteristic. Okay, now let's take thyroid hormones. How do we get the normal range for thyroid function test, right? Now, if you take, let's say 100 healthy people, right? What they take is the middle part of that 100 healthy people. That means there will be some healthy people whose values are disregarded and some whose low values are disregarded, and some healthy people whose higher values are disregarded. So what they take as normal is basically an arbitrary cutoff range of between 2.5 and 97.5 percentiles, right? So what we term as normal range is a very arbitrary, non-scientific range. Okay, very often. Now, let me give you an example. Let's say a lady, Mrs. Shanti, who is a 50-year-old lady, comes with clinical symptoms of hypothyroidism. Okay, she complains of vague things like fatigue, increased sensitivity to cold, some constipation, dry skin, a bit of weight gain. Now, when you do the blood test, it appears to fall within the normal population range, right? Now, what is the problem with this population range? Now, some diseases like hypothyroidism are basically a biochemical definition, right? But the biochemical definition, the range itself is an arbitrary range. Okay, that means some people who really do have hypothyroidism will not get treated, and some people who don't have hypothyroidism may get treated, right? So basically we define it as a TSH level above the reference range and the free thyroxine levels below the reference range. Now, whether the existing reference range should be used to define thyroid dysfunction is also a matter of debate. And this issue is of clinical importance because the reference ranges are generally used as thresholds for treatment. That means you are treating a patient not based on their clinical symptoms or their functional well-being, but simply a blood test, right? Now, so this part of it I've taken from an article from the Lancet. Uh, uh, Titled Hypothyroidism is fairly new, 2017. Now, let's say we had a crystal ball, okay, where we can look into the past and future. So the problem with Mrs. Shanti is she has symptoms of hypothyroidism, but the arbitrary biochemical tests are not corroborative, right? So what do we do? Now, if we had a crystal ball or whatever it is that astrologers have or whatever, we can go back and look at Mrs. Shanti when she was 20 years old. Now here you find that her free T4 level was 2, right? And the TSH level was 0.6. Again, it is within the normal population range, right? But she was comfortable with a free T4 level of 2. Now, when you see Mrs. Shanti at the age of 50, her free T4 level now has fallen to 1.2. Now, it is still within the normal population range, But for Mrs. Shanti, it is not comfortable anymore because she is used to that level of 2. So when it drops to 1.2, though the test looks normal on paper, she doesn't feel normal. Functionally, she doesn't feel normal. Okay, that's what I'm trying to say. So the current values are within the population normal, but it's not normal for her as an individual patient, right? Now, for most patients or for many patients, we do not have their blood values from the time when they were young. Okay, there are very few people who have been taking their blood, they are doing their entire blood investigations on a yearly basis or every 5 years. Most of us won't know what our normal levels are when we were young and functioning well. Okay, so this sort of worsening trend will be missed if we do not have the older blood reports for Mrs. Shanti, right? So this is what functional medicine is about. They don't rely just on the population reference range, which is a very arbitrary figure, but they also take into consideration how the patient functionally feels, okay, how the patient feels. So functional medicine understands that patients outside the normal laboratory range can still be clinical normal, and patients within the normal laboratory range can still be clinically abnormal, right? So what functional medicine basically does at its core is to treat individual patients as N of 1 clinical trial. That means each person is their own clinical trial. The data for their future treatment is going to be generated from themselves, okay? Whereas in normal medical practice, we treat patients based on data generated from other patients. But for these patients, we treat them with data generated from themselves, right? Now, what they do is they will probably give you a trial of treatment. Say, okay, let's try the drug and see whether it works or not. Of course, I'm not advocating anything, right? Because when you give one drug, it might be, it might treat that problem, but it can cause some other problem. So I'm not advocating anything. I'm just giving you an example. Now, the problem with N of 1 clinical trials is because it has not been tested on other people, so we can't give you a percentage and say that, oh, it worked in 20% people, only 1% had side effect. We can't tell you such things because we don't know. You are your own clinical trial, right? But usually people do this personalized medicine with drugs with good safety profile and high therapeutic index. That means it's very unlikely that you will suffer any damage or injury because of this particular drug. That means not all drugs are suitable for N of 1 clinical trial for personalized medicine. And like any other clinical trial, you can do randomization with placebo versus active intervention. So this N of 1 clinical trial is a very useful clinical tool, right? But it's not very well understood among the medical community. So there are doctors going around saying that, oh, functional medicine is a fake field. No, it's not. Okay. So why does functional medicine have such a poor reputation? One is our outdated medical curriculum. The medical curriculum that we teach now is not fit for purpose anymore, okay? It has to be completely overhauled, right? And many doctors have a very poor understanding of research methodology and statistics. So they don't understand the mechanics behind N of 1 clinical trial. And a lot of doctors also lack understanding of how reference ranges or normal values are derived, right? So they just take it as gospel truth. Whatever they see the normal value, that's supposed to be gospel truth. And then they also lack understanding of the concept of cutoff values. Okay. Now, for example, blood glucose. We don't really know what is a normal value for blood glucose, but we have cutoff values above which we call you a diabetic or a pre-diabetic, right? And how we arrive at this cutoff values can sometimes be quite controversial, and it may not be agreed upon by everybody, right? A good example is diabetes. If you look at the history of diabetes and diagnostic criteria for diabetes mellitus, you will find that this ongoing what shall I say, disagreements about cutoff values is there, right? And a lot of doctors actually lack understanding of the role of N of 1 clinical trial in daily clinical practice. It's a very clinically useful tool. Right. As I was saying, another area where which will be very helpful for you to understand functional medicine is to look at the history of diagnostic criteria for diabetes mellitus. I remember when in the 1980s, I think the time when I was a medical student, your fasting blood sugar must be less than 7.8, and then sometime later it was brought down to 7 millimoles. And then now we also have a pre-diabetic classification. So we can see that they have evolving criteria, right? And we can see that when you have old and new or different criteria, the patients can overnight be called diabetic. That means yesterday I'm not a diabetic, my results are considered normal, but today because of changing criteria, my results are considered abnormal and I'm classed as a diabetic, right? So obviously these sort of things are not logical, okay? Not logical to a patient and not logical to a lot of doctors as well. So that is how functional medicine sort of evolved, from what I can tell, that you also want to look at how the patient is, right? And take into account other factors which are very unique to this particular patient and you can't apply it to others. So please have a read about the changing diagnostic criteria for diabetes. It will give you a good understanding of the role of functional medicine. So as usual, if there are any errors, please let me know. I'll make the corrections on my Facebook and YouTube pages. Thank you very much.